All right, good afternoon, everybody. I see by my clock it's just about 1:30, and I'm just scanning our list of participants to confirm. I think we have just about everyone present. In terms of work group members, I see Jeff Brown, Kimberly Hendricks, JJ Schofield, and Sean Parkman. And Tom Siltabo will not be joining us today. He is out of town. So I think from the perspective of our work group members, we have everyone here, and I'm just scanning the list. I know we have a number of presenters today, and it looks like just about everybody is signed in. So I think, Jeff, we can go ahead and kick off at the top of the agenda whenever you're ready.
There we go. So I will call to order the May 17th meeting of the Innovation Work Group. And the first order of business, as always, is approval of the meeting synopsis from our last meeting. Does anybody have any comments? Motion to approve?
So moved.
And a second?
I'll second it.
Great.
Kimberly.
All in favor?
Aye.
Aye.
Aye. So let's move on. First presentation today is from the Health Authority on the Cost Growth Target Program. And Sarah Bartleman, I believe you are our presenter.
Yes, and welcome, Sarah. Sarah is the program manager for OHA's Healthcare Cost Growth Target Program, and she is going to speak with the work group today and share a little overview of program implementation, including sort of the general roadmap and timeline, and also information about the accountability structure. And before we dive in and I hand it over to Sarah, I'm just noticing a hand is up. And it looks like it's James. Did you intend to have a hand up, or is that just a mistake? All right, well, hearing no questions related to that, we will charge forward. So Sarah, I will hand it over to you. Thanks so much for being here.
Yeah, thanks for having me. Okay, I'm going to go pretty fast through some implementation status updates and just give everyone a bit of the lay of the land. I know you have questions about accountability, and we'll make sure we have plenty of time for that part of the discussion. Let's go ahead a couple of slides, please. One more and one more. Okay, so just to reground in the Cost Growth Target Program's annual cycle, this is what we will be working through every year. So we will be collecting data from all of the payers, measuring performance relative to the cost growth target for payers and provider organizations. We'll be doing additional analysis to understand the cost growth drivers and those cost trends. We'll be publishing performance reports and holding public hearings. And ultimately, we hope that will lead to identification of opportunities and strategies to slow cost growth and to address those cost growth drivers. There are a number of venues in which that identify and implement part of the cycle will happen. Some of that will be with our new advisory committee that I'll talk about. Some of that may be with you all, and some of that may be with payers and providers internally. So we are just coming out of our first round of measurement from some initial data collection and getting ready for some first public reporting. Next, I want to highlight a couple of milestones that we have accomplished since the program has launched. On the next slide, please. Back in January of 2021, the Cost Growth Target Implementation Committee submitted their recommendations report to the legislature. That has been the foundational document for program implementation to date. That was the document that codified setting the target, who that target applied to, and how we would operationalize a number of components of the program. In February, we launched a technical advisory group, mostly consisting of payers who are the data submitters for this program, but also open to stakeholders and provider organizations as well. In June, House Bill 2081 passed. This was the second bill establishing the cost growth target program. It gave the agency the authority to institute accountability mechanisms for payer and provider organizations that exceed the cost growth target without a good reason. And so now we are sort of fully authorized by statute. In October, the initial cost growth target data submission was due. We had agreed that we would collect baseline data from calendar years 2018, 19, and 20 to understand the lay of the land sort of before COVID. And that data was, the submission and validation began in October. In November, we filed rules finalizing and codifying the data submission process. And in December of last year, the implementation committee sunset. So this was a legislatively sunset date. This was not intended to be a permanent committee. They met their goals and did met their deliverables, and they sunset. However, one of their recommendations was that there should be a predecessor committee or that there should be a successor committee that would continue to guide implementation of the program, and that led us to some work that I'll talk about in a minute. And then the other big milestone I want to highlight was that in April of this year, just a couple of weeks back, we held our first public hearing. And this was a virtual hearing focused on the impacts of high and rising healthcare costs to Oregon consumers. And if folks didn't have a chance to listen to that, I really strongly encourage you to take a look at the recording, take a look at the compiled public testimony that was submitted. There are some really powerful stories of the impact of healthcare costs on people in Oregon. And we were really pleased with how that day went and how that sort of really grounded the reason why we are doing this program and why we are working on cost containment overall. Okay, and next slide. We have been working since October on that initial data submission. This was the first time we ingested that data, and we wanted to make sure that it made sense and that we understood it and that the payers understood what they had provided and that we were all in agreement. And so we have actually, we're a little bit better off than this when I made these slides. We are now at 99% complete of our first validation. We have just one file outstanding. That's just a small fraction of covered lives in Oregon that's left in that file. So we are almost done with validation. This was a huge lift from payers and from our team in terms of getting through that. And we're really happy to have that as a foundational step done. The next piece is taking that initial data, that calendar year 18, 19, and 20 data, and starting to work with provider organizations. And I'll talk more about that in the next section. So let's switch gears and talk about the Cost Growth Target Advisory Committee. Next slide. So as I mentioned, the implementation committee recommended that we have a future governance group. This would be a committee that would sit under the Oregon Health Policy Board. And we've been working with the Oregon Health Policy Board since last summer on figuring out what the right charter is, what the right membership slate is, what makes sense for this new committee, given that it is no longer legislatively mandated, and given that we're moving into implementation, and how are we prioritizing health equity, and what all makes sense for putting this committee together. So I'm really happy that 2 weeks ago, the policy board appointed the advisory committee. So we now have an advisory committee. It had been a long time coming, but we now have members and we are moving forward with this body of work. Next slide, please. So the Cost Growth Target Advisory Committee has a number of things that they will be responsible for. Primarily, they will be responsible for looking at those cost growth trends and cost drivers, looking at the data, hearing from payers, providers, stakeholders, understanding what's going on, and then identifying those opportunities to reduce cost growth. So you've probably heard us say, or in other venues, we say it's not enough to just have the cost growth target. We have to actually be doing something about it. There have to be some strategies. And so the Cost Growth Target Advisory Committee will be really key in coming up with some of those strategies. Some of those might be recommendations back to the policy board. Some of those might be recommendations for future legislative action. We don't know yet, but that is a body of work that the committee will be tackling. They'll also be looking at opportunities to improve equity, monitoring for negative impacts of the target, so making sure that as payers and providers work to meet the cost growth target, access isn't being hampered, quality is not declining, things like that. They also have one very specific charge, and that is in 2025, they need to revisit the cost growth target value. So the cost growth target is currently set at 3.4%. For 2026 to 2030, it will drop to 3.0%. unless it is otherwise modified when the advisory committee reviews the data and understands the landscape. This will be a big charge for them, especially given everything we know about what's happening with inflation in this country and healthcare inflation tending to lag. And so what the landscape will look like when they have that conversation in 2024 and 2025 and revisit the cost growth target value will be a detailed conversation. They will also oversee ongoing program implementation, provide guidance to the program and to the state when needed, and inform our public hearings. On the next slide, I have the roster in case anyone is curious. You can also find that online. It's a larger committee. We have 20 members plus 3 ex officio members. You might see some familiar names here. And there is more detail both in the roster and in the presentation we gave to the policy board in May, if anyone's curious. And next steps for the advisory committee on the next slide, we're holding orientation sessions for the new advisory committee members, and we are working on scheduling the advisory committee meetings for the rest of this year. So we intend to have our first public meeting in June. And then following that, we'll do July, October, and November. So hoping for 4 meetings before the end of the calendar year. As soon as those dates are finalized, we will be making that information on our website and going back to all of the normal public meeting notice announcements and all of that. And I feel like I just talked an awful lot. I'm going to stop for a second. Are there any questions about implementation status or the advisory committee before I talk about providers?
Don't see any hands raised.
Okay, great. I will keep going then. So
Thank you.
let's talk about provider organization and provider organization outreach. So refresher, the cost growth target applies at 4 levels: statewide, market level, insurer level, and provider. And we've been hand waving this provider part of the program for a little while for a couple of reasons. We weren't there in implementation. We were having COVID surges, and we were asked to hold off on outreaching to providers and engaging providers to make sure that the health system could have time and space to address COVID. But we are now moving into this phase of the work. So when we are talking about provider organizations for the cost growth target program, we are specifically talking about large provider organizations. We are not talking about individual clinicians. We are not talking about mom and pop shops. We are talking about large health systems, large organizations that meet a couple of criteria. And on the next slide, those criteria are twofold. So the first is that we're talking about provider organizations that can be held accountable for total medical expenditures. So these are organizations that could, in theory, take on contracts for total cost of care. They don't actually have to have a total cost of care contract in place. They just, in theory, could be positioned to do that. So this would be organizations that include primary care providers and have some mechanism where they could influence where a patient could receive care, reasonably so. So this includes health systems, hospitals that have primary care providers, medical groups with primary care providers, and a subset of specialists that provide care coordination or primary care-like services. Then our second criteria is provider organizations also need to have sufficient patient volume. We know there's a lot of noise and cost growth can shift really dramatically. Costs can swing really wildly with 1 or 2 different patients and what happens to them in a year. And so we wanted to make sure that we had some sufficient volume before we held any provider organizations accountable and included them in the program. So these provider organizations have to have at least 10,000 unique all-payer attributed lives, or at least 5,000 attributed lives in any one market, so Medicaid, Medicare, commercial. So it may be that an organization only has 5,000 attributed lives for Medicare and not Medicaid and commercial. That's okay, they would be in, but we would only look at their cost growth for Medicare in that case. We originally had talked about attributed lives. Because of how we're collecting the data, we're doing that in member months, so we've converted to member months. So at least 120,000 member months across all markets is our threshold. So figure out which provider organizations in Oregon actually meet these criteria. So, excuse me, on the next slide. In the data submissions that all of the payers have submitted to us, they have attributed their members to providers. And they have done that using a hierarchy of attribution. So if members have member choice, if they've selected a primary care home, for example, or if they've indicated they have a PCP somehow, that is default attribution. If the provider payer has a total cost of care contract or other contracting arrangement specifically assuming responsibility for those members, they're attributed in that way. And then third and finally, there's a utilization-based attribution algorithm. So, and not everyone is attributed. So there's a whole bunch of unattributed members, but for any health plan members that could be attributed in one of those three categories, they were linked in the data submitted to us to providers. We were able to take all of those payer data submissions, merge all of the data, and then roll it up. So we were able to say, all right, we had these organizations are all the same organization. And I'm hand waving all of the methodology on this. I do have a write-up and much more detail that we can share if anyone's interested in the technical details. But we were able to essentially create these master variables of organizations and roll up the number of lives that payers were attributing to those provider organizations. Next slide. The end result of that is we found about 50 provider organizations that meet the criteria out of that initial data submission. So looking at 2020 member months. And this is just a snapshot of that list. You see the usual sort of who you might expect to see from a large provider organization perspective here at the top. And you can see the full list is linked in this PDF on the slide. But when we're talking about rolling up to that large provider organization to the highest level possible, we're talking about Kaiser, the health system. We're talking about Providence, the health system. We're not talking about one specific Providence clinic is accountable at that entity level. We're talking about Providence writ large, Providence, their whole health system, their whole delivery system side of things. So this has been really confusing in terms of who are we talking about and do I apply and do I get rolled up and where did I get rolled up? But now that we at least have this list, now we know who we need to be talking to and where those conversations need to be happening. So next slide. Last week, we started official outreach to these organizations. We sent them all a notification saying, hey, you've all been identified as a provider organization for the Cost Growth Target Program. Here's what that means for you. There are some opportunities to engage. We'd like to invite you to an orientation webinar that we'll be holding next week. We would like to set up one-on-one meetings with you and your team, whoever the right mix of folks are for your organization. And we'd like to sit down and start reviewing data with you. We are going to bring that 2018, 19, and 20 data to them and say, this is what the data say is happening at your organization for these attributed members. Let's talk about that. What do you have in your data? What makes sense? What doesn't make sense? So none of this provider work is going to be public facing yet. None of the 18, 19, and 20 data will be published at the provider level or at the payer level, actually, only at the state and market level. But we're going through this exercise to make sure that we have the right contacts, that all provider organizations who are part of the program know that they are part of the program. And we've had that opportunity to really bring them on board, answer questions, go through the details, build trust in the data and the data process. And possibly there's this third sort of closed loop thing, component of this piece. In some cases, we will need to engage the payers because it's the payers that are the ones providing the data. We might need to pull the payers into some of those conversations with providers. So we expect this will be a very iterative process. It's been 6-7 months on the payer side. And so now we're entering that validation cycle on the provider side. And not all provider organizations on the list have been aware of the Cost Growth Target Program. Once we sent out the notification, we got a lot of immediate responses like, can I opt out of this program? And how was I selected for this program? So we really have a lot of work to do in terms of making sure providers are, provider organizations are aware of this effort and why we're doing this and how this all fits together. And unfortunately, we're late in the game. I think we really had wanted to do this earlier and we were delayed by COVID. And so we're sort of playing catch up now. And I think provider organizations, some are going to feel a little surprised that this is happening and how did I not know about this? But we're going to be doing what we can over the next couple of months to help orient them and introduce the program. So that's where we are with providers. Any questions about that? Okay, let's talk about accountability. So next slide, please. Our accountability approach really has three pillars, 3 steps, 3 phases to it. And so the first thing that we are doing for the accountability aspect of the cost growth target program is ensuring statistical confidence. So only payers and provider organizations that exceed the cost growth target with statistical certainty might be held accountable. So before we even do anything else, we are going to do some statistical testing and see whether or not there's some certainty that that payer or provider organization has exceeded the cost growth target. If there's noise in the data, if there's not certainty, then the accountability chain, the accountability flow stops there. And we just go into public reporting and we say, all right, these were all the organizations where we couldn't tell. Here's what cost growth target performance looked like, but we're not going to make any determinations. It was in that gray area. For those, and this is something that our implementation committee wanted us to do. It's an approach that's been adopted by several other cost growth target states now, and it really will help control for some of those small numbers and noise in the data or random events. After we've done that, we move into these conversations to understand the reasons for exceeding the cost growth target. And then only payers and provider organizations that exceed the cost growth target without a good reason would be subject to any accountability measures. That without a good reason list is a bit of a moving target. We have some guidance from the implementation committee that is going to be the foundation of that. We'll be doing some additional work with our advisory committee later this year. We'll also be doing rulemaking to codify this next year. But really, we're thinking about things that are within an entity's control versus things that are not within an entity's control. So the legislature says you must cover this new expensive benefit. That's a mandate. That's not in your control. If that was the reason you exceeded the cost growth target, that would not be a reason that would subject you to accountability measures. If you raised prices as much as you could because you felt like it, that was in your control, that may not be a justifiable reason. You might be subject to accountability measures in that case. So we are trying to walk the line between providing guidance and clarity and also understanding we can't anticipate every single thing that will ever happen. And so how do we have a flexible enough framework that will guide these conversations? The first accountability measure that would kick in after an organization was found to have exceeded the cost growth target for not a good reason would be a performance improvement plan. That is the starting place, and there are some more details on that I can talk about in a little bit. But then the third and final piece of accountability would be for payers and provider organizations who exceed the cost growth target repeatedly. So in any 3 out of 5 years on a rolling basis, exceeding the cost growth target with statistical certainty without a good reason, then there would be a financial penalty. So that's the overall framework for the accountability measures. I'm going to talk a little bit more about the details. Let's go ahead a couple more slides. Understanding performance, identifying those factors driving the cost growth. Again, as I said, we expect this to be iterative. There'll be some back and forth. Provider organizations and payers will be able to say, this is why we think we've exceeded the cost growth target. This is what our internal data say. We'll say, here's what the data that we have says. Let's talk about that. Let's agree on the reasons. In some cases, there will likely be multiple reasons. And so then there's a sort of, to what extent did each reason contribute towards exceeding the cost growth target? For example, we know labor costs are a really huge concern right now. And we know that coming into these conversations for the 2021, 2022 measurement periods, everyone's going to be saying, well, my labor costs are so high, and that is the reason my cost growth is high. Labor costs are high, yes. We are going to want to take a really close look at that and understand whether or not it was labor costs that was sort of what tipped you over the cost growth target in that. Whether or not that can be definitively hammered out in every single situation, we don't know. Again, trying to find that line between providing some clarity and some guidance, but also being flexible enough to know that situations are changing and there are different things that are happening all the time. A new drug entered the market. You had one very, very high cost outlier patient or member. That might have been much more of a cost driver than your labor costs, for example. So we're going to be teasing that out in those conversations. Next, I talked about that determining reasonableness and the good reasons. And then on the side, there are a couple of those criteria that the implementation committee had identified. So changes in mandated benefits, changes in federal or state law, acts of God, investments to improve population health or address health equity, new treatments and products entering the market, and changes in taxes and other administrative factors. As we go into additional conversations and rulemaking, we expect this list will grow. Okay, so let's talk a little bit more about the performance improvement plans on the next slide. So we are currently working on developing the PIP process and the PIP template, and we'll be bringing it to our technical group as well as our new advisory committee for some additional review and vetting in the coming months. But we have some guidance that we're working with, and that is PIPs are intended to be collaborative. So OHA will provide guidance, OHA will provide technical assistance to organizations. There'll be some opportunity for iterative review back and forth. Here's what we're thinking our PIP should be. Does this make sense? Will this be acceptable? That kind of back and forth. PIPs should be multi-year to allow time for improvement. PIPs should be related to the reason that the entity exceeded the cost growth target. So if it turns out that the reason for exceeding the cost growth target was contracting with a specific provider organization, the PIP should be related to that. Are there mitigating factors? Are there ways to address that in a future cycle? We want to see some connection of how work and activities under the PIP will help address what those cost growth drivers were. There will be regular progress reporting on the PIPs, and both the PIPs and the progress reports will be made publicly available, again, coming back to the program's commitment to transparency. And then finally, on the financial penalty side, next slide, we have a lot of work to come on developing this. The guidance that we have from House Bill 2081 says that the financial penalty should be meaningful. So there are lots of interpretations of what that could be, and we will be working through options and presenting them to our advisory committee for discussion, for public comment, for feedback, as well as full rulemaking next year on what and how those financial penalties are calculated. And I know this might feel a little bit like there's so much happening, and yet all of this is not hammered out yet. How do you not know any of these things, Sarah? And part of that, especially on the financial penalties, we have a little bit more time because accountability phases in. So on the next slide, you can see just a really rough timetable here. So PIPs do not apply until our second year of cost growth target data collection. So until we collect the 21 and 22 data, which will be submitted in fall of 2023. So we are going through this initial baseline data cycle. We're going through a data cycle this fall. PIPs will not apply based on any of that. So there's still a whole another year and a half before any organizations would be put on a PIP. And then financial penalties would not apply until year 5. So looking at that full first 5 years and performance in any 3 out of 5 years. That will be data submitted in 2026. And likely the soonest we would be issuing a financial penalty would be in 2027. So again, you can see there's a pretty long runway here for some of these mechanisms. Okay, and next slide, next steps for accountability. We are drafting the template, the process, the guidance documents, all of that around the PIPs, and we'll be reviewing that with the TAG and our advisory committee this summer. We'll be starting to talk about those financial penalty options this summer and fall, but we won't be doing formal rulemaking and the Rules Advisory Committee process on this until next summer. Again, because we have that runway, we want to make sure we're taking time with our stakeholder groups to do some development. There's also legislative session coming up, and then we'll do rulemaking after that in plenty of time before any of these mechanisms actually apply. And I'm going to stop there for questions.
Sarah, thanks for the presentation overview of all this. It is a lot going on, so thanks for all the work. I have a question, and it's gonna take a second to wind up. And it's not really answerable. It's more of a, maybe it's more of a request, perhaps. So just to cut to the chase, my concern is that there is a professional army in in healthcare whose job it is to maximize their profits, and that is a job. And so with the how you will actually the rubber meets the road when it comes to provider networks, I feel. And so given that many of them were not aware of this or weren't tracking or whatever, it's not like their boardrooms have come to the reality that they are going to contain their costs. I don't think they have any intention of doing that. So by way of explanation, I have this acquaintance, and this person works in health, and that's actually their job. Is they're one of these coders, and their job is to figure out how to make the most money, given what the providers did, by coding things correctly. And so their job is to like look at the thing that costs the most, and then just like code them within the bounds of the rules. And it's like, they have a whole team. That's what they do. And so once the rules of this get established, medical investment you mentioned is allowed, like outside of the, suddenly, like, once they figure out what they get penalized for, that's the thing that they're going to start to recode as. And then, so what is the plan, or what are the tools you have? Or, like, do you also have a small army of analysts? Because it's sort of an analyst versus analyst battle, to be frank with you, when you're trying to control costs, because there's a group that's their job is to maximize profits based on just like bureaucratic coding. And so they will be year by year trying to defeat your team, which is, trying to figure out how they're, moving the shells around in order to like make more money. So like, what are your thoughts about that? And, did the advisory committee kind of like take that head on, or like, what are your thoughts?
That is such a great, right to the hard questions, Sean. Thank you. I think I have a couple things in response. So yes, this is absolutely an issue that we are aware of. It is out there as something that needs to be addressed. Whether or not it can be addressed with any one single mechanism versus something that we're looking at and trying to work on in multiple venues is probably the case. I will say our counterparts in Massachusetts are all over the upcoding analysis and have been doing an incredible amount of work and sharing their findings with us. We've been really happy to benefit from their small army of analysts and what they're learning. So there are definitely some things to do analytically to monitor for this. I think that there's also quite a bit of federal attention on this. There were several high-profile fraud cases recently that broke around upcoding. I think I would hesitate to say that upcoding specifically is going to be the one thing that causes any given organization to exceed the cost growth target. I think proving things like that gets sticky. And so that's where we're going to be in these conversations of, all right, in the data, it looks like your cost growth has grown. You've exceeded the target in commercial. It looks like it was commercial, and it looks like it was because of outpatient services. It looks like it was these specific types of outpatient services. Let's talk about what was going on there. So it is an exploratory thing. I don't know that it's as sort of as gotcha as trying to like outcode somebody in real time. I do think that this is going to be an ongoing conversation and thinking about what mechanisms need to be identified. So these are conversations we would expect the advisory committee to have, that we would expect our other stakeholder groups to have, that we would expect payers and providers to be having themselves, right? The payers also have an interest in this angle as well. Payers should be tracking this and can be tracking this. And one of the reasons the state Oregon has the cost growth target approach is to bring people together with a common goal. And so to the extent that payers and providers can come together, and the payers are carrying some of that conversation, and the payers are using their tools to look at this, that will also help. It's not just sort of on my team to be doing that. So I feel like I gave you a really wishy-washy answer, but this is a known issue, and I think there are going to be lots of different ways to try to address it. And I think you're right. As soon as any organization, payer or provider, understands what's acceptable cost, or what's a good reason, then that's where we'll see costs being diverted, and hopefully those criteria are designed in a way that we see that in a good way. We want primary care spending to increase. There's probably a really good argument that we want behavioral health care spending to increase. We want investments in population health. Those would be good things. It's not that all spending growth is bad all the time forever. And so it's making sure that we're being really careful and selective about what we're incentivizing. And I'm at time, I think, Margaret. So unless there's anything else, I will cede the floor.
Yeah, thank you, Sarah. That was a lot of really good information. So really appreciate you being available. Are there any final questions before we move on to our next agenda topic? I'm seeing applause and thumbs up and no more questions. So Sarah, thanks again. We will certainly stay in contact. And I know this group is very interested in staying in the loop about how things with the advisory committee progress and all of the work that's queued up for the coming year that you described.
Great. Thank you for having me. And we can let you know when the advisory committee meetings are scheduled.
Great. Thank you.
Thank you. Well, we move on to report on APAC. And since I've got so much construction noise going on in the background, so Margaret, you kind of do the transition. Thank you.
Yeah, certainly, Jeff, no problem. Happy to help with that. So next on the agenda, we are going to hear from Yushan Sung and Zachary Goldman, who both work with the all payroll claims data within OHA Analytics. And specifically, the data that they have to share today is from the what's known as the payment arrangement file. It is a specific data file within APAC that carriers submit once annually that describes their value-based payments. And so there is not a paper attachment for this agenda item. Some of the data that you're going to be seeing today specifically for 2020 is kind of newly released, just hitting the website. So Rose, just to kind of check in, I think in terms of screen sharing, I think either Yushan or Zachary will pull up the, there's a web-based platform where this data is housed and it's interactive that they'll walk through. So I think it'd probably work best if we let them go ahead and take control of the screen for this portion of the presentation.
Yeah, sure. This is Yushan Song. Let me share my screen quick. Can you all see my screen?
Yes, we can now.
Okay, great. Thank you. So,
sorry. And Yushan, just to note before you get started, I will also go ahead and put the link to this Tableau report into the chat so that folks can access that if they'd like.
Yeah, sure.
And I can go ahead and do that for you.
Oh, yeah. So for the 2020s one, it's still not available yet, but we do have the 2019's data link available. So thank you, Margaret.
Right. Yeah, perfect. I will put the 19 link out there.
Yeah. Great. So yeah, let me go start. I'm a Yishan Song, a research analyst with OPL Claims Program and Cost Growth Target Program. So I'm going to go through this VBP data and then some background and methodology. And after that, I will hand it to Zachary to give more information about how the carriers and CCL react to this report and what's our plans for this report for the future. So just a little bit background about this report. Oregon is one of the few states collect the VBP data, or we call it non-claims data. APAC program start to collect this data since 2017 for the data, which is in calendar year 2016. And starting last year, we start to publish this VBP report using the 2019's data. And just a little bit background for this report, the purpose is to support the Oregon's value-based payment compact. So Oregon is trying to increase the payments in VBPs. This report is also being supported by CCO 2.0, which CCO are required to have at least 20% of their payments being in VBP in 2020. And by 2024, CCOs are required to have at least 70% of their payments in VBP. This report is also being great interest for the cost growth target program, since VBP is part of the solution for to meet the cost growth target. So for the data, for this report, we are using the payment arrangement file, which is collected by APAC program. This data is being submitted by the carriers and CCOs by end of every September, and these are the payments being submitted by contract, by payment category, and by market. So speak to the payment categories. Payment arrangement files are using the healthcare payment learning and action network, alternative payment methodology framework, or we say LAN categories to do this payment category. And we have one Oregon homegrown category, which is 1A fee for service linked to APM payments. And for all these 12 payment categories, there are some hierarchy relationship between that. So for the payments no link to quality, that is the lowest level. And then for the 4A, 4B, 4C, the population-based capitation, that's the highest level for the payment category. And before I jump into the data, I just want to give you a little bit more information about our methodology. As I just mentioned, the payment category has a hierarchy structure. So for one contract may have multiple payment category involved in that case, we will use the highest level category for that contract. So for example, if a contract has $75 in category 1 fee for service and another $5,000 which is quality incentive payment for the category 2C, in that case all the $80,000 for that contract will be categorized 2C. We also use the proration. So one contract may not exactly starting and end in the same calendar year. In that case, the dollars will be prorated. And we also use the absolute value. We recognize that some of the payment category, for example, 3B, the risk sharing and saving, that could be the negative payments, which means the provider pay back to the payers. In that case, because we don't want to deflate the VBP components, and then we use the absolute value for that payments. So let's dive into the data. So first, I just want to show you the data by market level for the 2020. So at the market level, we see the commercial has the highest percent of the VBP. For 2020, we consider payment category 2B or higher as the VBP. Normally, we consider 2C or higher, but because due to the COVID effect, we use a 2B and higher for 2020. But after that, we will still using the 2C or higher. And for the commercial, they have the highest of 54, and then it's followed close by the PAB and OAB, which is 52 for the payment category 2B or higher. And then Medicare Advantage has the lowest one, which is 43%. And use this drop-down list, I can show you like payment category for 2C or higher, which is very similar to the 2B and higher. We can also compare this data to the 2019 data. So for the 2C and higher, you can see for the PAB and OAB commercial, they are quite similar, maybe a little bit increasing in the 2020. And using drop-down list, we can also get the 3B or higher and 2B or higher. So that's the data by market level. So if we can also use this tab to go to the payments category by the carrier level. So as you see, the Kaiser has the highest level of the VBP, where 100% of their payments are under 4C, and then Moda Health has about 56% of layer payments under 3A and the 1% under 4A. And then the Providence has a 9% of the 2C. We can compare these carriers labels data to the 2019 as well. Yeah, so the KAISA are pretty much the same. And we can see the model in 2020, it seems like they move more their 3B payments under 3A, because in the 2019, they have more payment category under 3B. And the Providence is pretty much stable from 2019 to 20. It's have about 9 to 10% of their payments under 2C. So any questions so far for the data? If not, I'm going to touch a little bit on the CCO. So starting from this year, we have a separate tab for the CCO's payment arrangement or VBP. This is because for the CCOs, we include both the medical and dental payments, as the dental is part of their covered benefits. And in general, for the category 2B or higher, the average CCO has about 50% of their payments under the VBP, and all of the 15 CCOs meet the goal, which is 20%, at least 20% of their payments are under VBP. So that is for CCOs. Any questions so far for the data? Hearing none, I just want to say this report will be, the 2020 data will be published very soon, like in weeks, and the link will be available to share now, later on. And this report will be published annually, so we have the data being submitted by the payers in September, and hopefully we will have the data usually available in January and February next year. So if here no questions, I'm going to hand it to Zachary for more additional information about the VBP data.
Thanks, Yushan. Great presentation, and thanks for walking everyone through these data. I just want to add a couple points to close here. One is that I think Oregon's, and Yushan mentioned this, but Oregon's really kind of at the forefront here of not only collecting these data, along with the claims data that just naturally comes in through the claims processing mechanisms, but also in publishing it and just trying to be really transparent about where we are as a state and which markets are maybe doing more VBP than others, which carriers may be doing more VBP than others. So I think at its face, it's really interesting, and we're proud of this work. The next thing I'll add is, and it's a little focused on the Medicaid space, as just a reminder, so as part of the current CCO contract, CCO 2.0, which runs from 2020 to 2024, there are increasing requirements for CCOs to meet certain value-based payment thresholds. And I'm sure you all are very aware of this, and I've talked about it before. And so to bring this back around to how this relates, these data here that we're looking at, these are kind of the accountability mechanisms to see where those CCOs are investing more heavily in value-based payments, which ones are not, which ones are meeting that contractual requirement. So I know there's been talks among the PEBO Innovation Workgroup about what would that look like? Should there be something similarly, and what thresholds, and all those really important questions. All that to say, hopefully these data can also serve as the accountability mechanism and the transparency tool for those efforts. And I think that's all I have. We're happy to answer any questions.
Yeah, this is really helpful. Bottom line, my question is, how as a field, as a whole, how do they do? Are they on target for the target?
For the CCO specifically?
Yeah, right.
They are, yes. The 2020 requirement Again, I know we're in 2022 now, and due to the data lag, we're looking at 2020 payments. That contractual threshold was 20%. So 20% of their total spending had to be connected to a value-based payment. And every CCO has met that 2020 threshold of 20%. Now it does in 2024, it gradually increases all the way to 70% in 2024. And so we'll have that data, say, at the end of 2025, and we'll be able to see how well they did for that much more aggressive target.
Can you remind me? The targets are, I don't think that the targets require them to get up to level 4. I can't remember, but how, like 70% getting into 2B, you know, or is it like they have to keep moving up, you know?
Yeah. Let me clarify. So the addition of 2B was really a kind of exception just for 2020 due to COVID. Moving forward, starting in data 2021, payments that are made in 2021, it reverted back to the 2C or higher. So anything pay for performance or in category 3 or in category 4. And that's the percentage that gradually increases to 70% in 2024, that 2C or higher threshold. There's another CCO 2.0 contractual requirement that focuses on 3B or higher. And that comes in the latter years, so 2023 and 2024. It's not anything focused on category 4. It's just that 3B, that shared savings and risk and higher. And I believe that threshold is 25% and 30%, or maybe 35%. It's been a while since I've looked at that. I need to look at that, but it's around those numbers.
And Sean, this is Margaret, just to kind of chime in and add some context, because I'm realizing we're going to have some further discussion on this in the next presentation that will add context. But so for PEB and OEB, we are aligning with the annual VBP targets established in the Value-Based Payment Compact. And so those will be described more fully in our next agenda item, but specifically, those look at payments that are in advanced VBP models of 3A or higher, and also separate targets for models 3B and higher that specifically apply to primary care and general acute care hospitals. So we'll talk a little bit more about those targets in the next agenda item.
And allow me to clarify, my brilliant colleague just pinged me. So it's for the 3B or higher thresholds, it's 20% in 2023, and then 25% in 2024, the last year of CCO 2.0.
This is James Matheson. I had one question also. I think I understand, but I want to see if I can say it clearly and make sure I do. Yours is a contract-focused existence of VBP incentives, but do you have any data that helps you gauge the robustness of the financial incentives versus the existence? And do you have any data that helps you gauge the robustness of the quality incentives or metrics versus the existence of some?
Great question. So the data are granular to the different components of an arrangement. So, for example, if there's an arrangement with a quality incentive bonus potential, and let's say at the end of the year, after the claims run out, the payer rendered $5 million in fee for service, and then an additional $10,000 in quality bonus payment. In the data, we can see the fee for service, $5 million payment, as well as the $10,000 quality incentive bonus payment. We see those as two distinct rows. What we don't see in the data is how much that bonus could have been had the practice hit it out of the park on every measure. So maybe they could have earned a whole $1 million. We won't see that. The payment arrangement file is really an accounting kind of structure. And so we see actual dollars out the door. But we can kind of stratify, okay, well, the bulk of the payment was, was this, and really it was a $5 payment for some kind of quality incentive bonus payment. We can see that $5 or the $5 million or whatever it is. But we don't know what the specific metrics were. We don't know what kind of benchmarks were used for a given measure, nor do we know what it could have been had the clinic or provider group checked off all the boxes and did everything perfectly on those measures. I suppose one
Perfect. That's exactly what I was wondering.
Yeah. I mean, I suppose one could explore that after the fact with some interviews and discussions. I mean, that's all answerable questions. It's just not captured in our current data file.
Are there any other questions for Zachary or Yishan related to this data they've presented today? And Zachary, can you remind me, just for the benefit of this group, in terms of, I know this reporting is being staged on an annual cycle. Can you talk a little bit about the timelines? Like, when would we in theory see 2021 data?
Yeah, Yishan mentioned this a little bit. So the data come into us in September. There's a fair amount of validation and processing that goes into it. There are cases, and sometimes a payer needs to resubmit because there was an error, but we're trying to minimize those and limit those as much as possible. So ideally, the data would come in, say, in the fall. We would process it, analyze it to fill out these kinds of dashboards, and it would be ready maybe January, February of the following year. So for example, this coming September, the data are going to come in. They're going to reflect 2021 payments. And so January, February, maybe early March, but we're hoping January, February of 2023 will reflect those payments made for 2021. So it's like a full year lag. Understandably so, in that sense that a lot of these payments are they require some kind of reconciliation or a full claims runout. This is not our typical claims processing that is just we've been using a system over decades and decades to build it. So this does require a bit of manual work on the payers to fill out these data, and then we have to intake and process it.
Yeah, great. Yeah, certainly. That's helpful. Thanks. Any further questions from the group? All right. Well, hearing none, thank you both so much for coming to talk to us today. This has been really interesting. And as I noted, I have shared the link for the 2019 report in the chat. The 2020 data that was presented today is not live yet on the reporting portal, but once it is, we will certainly share that as well, so that everyone can have an opportunity to go out there, take a closer look, and play around with it. I think it's kind of a neat reporting tool, and that you can kind of slice and dice the data based on your interests and take a look at it in different ways. So we will follow up with that once available. And looking ahead to our next agenda item, I think we are technically at break. So we have a break until 2:40. We'll go ahead and give everyone 10 minutes to take care of what you need to take care of, and we'll reconvene at 2:40. Thanks. All right, welcome back, everybody. I think we're at 2:40. I'm just looking to confirm. It looks like we've got everyone back at the screen, so to speak. Jeff, are you ready to roll?
I have unpredictable power tool noise in my background. So.
Okay, sure. I can see you. It looks like you're set. All right, I'll take visual cues.
So go ahead and move us on, please.
Great, sounds good. All right, next up on our meeting agenda today, we're going to hear from Emery Chen and James Matheson at Mercer. Emery and James have been working with OEB and PEB carriers on collecting some status update information related to their value-based payment implementation, specifically focusing for this next presentation on primary care medical homes and behavioral health. So with that said, I will turn it over to Emery and James to walk us through the information they've prepared.
Thank you, Margaret. So we are going to take a look at primary care and behavioral health in terms of performing essentially a gap analysis. This was born out of essentially Lodestar 2.0 when we took a look at the Lodestar and identified key areas to help deliver better care. Primary care and behavioral health was one of those. And so what we wanted to do was tie that into the value-based payments and the support provided to primary care homes to help deliver better care to PEB and OEB's members. So this slide, the agenda shows some of the elements that we're going to be discussing today. First, an overview of the process, as well as a little quick description of some of the questions to the carriers. Next, we'll go over responses, quantitative responses, as well as qualitative, and some of the key themes. We did ask a lot of questions and there was a lot of information, but we kind of boiled it down into some where we thought might be some of the more interesting and potentially a little differentiating areas. So it's not nearly as voluminous as some of the responses that were actually provided to us. And then three, we're just going to talk a little bit about the value-based compact. I think Margaret kind of did allude to it earlier. We'll just kind of describe it, and I guess that would actually serve as a lead-in to the two carriers that are going to be providing comments about their progress towards the value-based compact. So moving on to the next slide, the overview of the gap analysis. So this is one of two that we have conducted so far. The second one was the behavioral health network work that was being done in prior IWG meetings. And what we did was to ask the carriers to respond to quantitative questions, essentially in that first box on the left, the percentage of medical homes by tiers, physicians, dollars, care management fees, and other data element. And some of those are summarized on the following slides. And we also ask for qualitative information on the value-based payment model. So questions about their quality metrics, additional written descriptions of performance guarantees, support, care coordination support, and things like that. This was done originally in August of 2021. They provided information using based on 2020. It was kind of put on hold due to the new COVID surge, and so we took a look again, started later earlier this year, and so we asked for updated data in April, and we requested data for 21. We also asked a few other questions related to VBP and impacts due to the pandemic, COVID pandemic. The data that we're going to show on the next couple slides actually reflects 2020 data because similar to APAC, 2021 is lagged, especially with a value-based payment. So not all data was available. Some of the carriers are going through and getting run out and then have to do calculations on value-based payment. So not all the information was uniformly available. So we just decided to show what was available for all of the carriers, which was 2020. Any questions? Okay, moving on, just to provide a little background on a medical home tier, because we do talk about medical home tiers and showing data split out by the different tiers. So the Oregon Health Authority, the PCPCH, or Patient-Centered Primary Care Home Program, they you can be a medical home in different tiers based on performance, attesting the performance and reporting performance on 35 core measures. It's like the themes are shown there. Make sure you're accessible, that you're accountable, that it's comprehensive, your care is comprehensive, it's continuous, coordinated, and it's patient and family centered. Based on scoring, you can receive a designation 1 to 5, 5 being the most stringent and the highest scores. And so, you know, the higher you move on the tiers, essentially the more you're attesting or trying to achieve those core measures, and therefore, I guess it would be implied that the care might be a little bit better in that as your tier designation, or you're trying to achieve, you know, follow best practices in that case. And on the following slide, we can take a look at OEB and PEB in total in terms of the providers and patients by the different tiers. So just to orient you on the graphs, the blue, light blue on the left of the 3 columns is MODA. Providence is green in the middle, and then Kaiser is the purple. So at the top, we have the providers, and then down below, we have the number of patients for OEB and PEB. So the providers, you know, it's total providers for OEB and PEB in those plans. So it's not duplicative in this case. As you can see, the majority of providers are actually in tier 4 and 5. MODA does have some that have no designation, but the vast majority then are over on the right-hand side, 4 and 5. Kaiser, these are their Kaiser providers. They do contract with a few medical homes, which was not providing the data, but these are their Kaiser actual physicians, and all of them are designated as tier 4 in this case. In terms of the number of patients on this graph below, as you can see, the distribution of the patients is very similar to that of the providers, where most of them are in tier 4 and 5. There are some with no designation under MODA, but the other majority is in tier 4 and 5 in this case. Okay. Any questions? Okay, moving on.
Second, Emery, sorry,
Yeah,
I was
ahead.
on mute.
That's
Going
okay.
back to the last slide. So if you've got 463 providers with Providence in tier 4, but you've got 42,000 patients, what am I missing here? That seems like,
Yeah, that's actually Kaiser. So the purple.
Excuse me. That's my color blindness.
I'm sorry. Yeah. So Kaiser is on the
Nonetheless,
right.
that's a huge ratio.
Yes.
Any comments on that?
I would
Emery,
probably go ahead.
Those are not individual human providers. Those are provider groups, correct?
No, actually, this is, well, no, these are providers. These are actual physicians. Kaiser has 17 medical homes and 463, which is shown on, I think, the next slide, but 463 actual providers. So, I guess, I mean, Kaiser is a closed system, right? So, for the most part, so they would want you to see their providers. They are centrally located. I guess I would leave it. I don't think I'm qualified to comment more beyond that. I guess if a Kaiser representative wants to comment on your question, I think, I don't know, maybe open up the floor to them, but.
Hi, Emery, this is Sapari. So the number of providers are unique provider counts. So, you know, our providers could be working at various facilities, various KP facilities, but they're only counted once by their uniqueness. And these are primary care providers. So specifically.
And Sapari, this is Margaret just chiming in with a clarification. So does that include MDs as well as physician's assistants or nurse practitioners that might be working in a primary care capacity?
Yeah, I believe I will have to confirm that, Margaret, but I believe these are MDs mainly.
Okay, that would be a great just follow-up clarification to get on the data to better understand who's included in that number.
Of course.
Yeah, I think you may be onto something, Margaret. If you've got nurse practitioners operating under a physician, that allows it to multiply more.
Yeah, less than 15% of our primary care workforce is physicians and physicians assistants and nurse practitioners. And in most of the way we do our data, that would be included as unique providers, since they're carrying their own panels or supporting clinic operations and seeing everybody's patients. But it's most are MDs or DOs in primary care.
Okay, thanks. That's helpful.
So I'd like to understand the leveraging there a little bit more, whether that be a follow-up. I appreciate it.
Definitely, Jeff. This is Sapari. I mean, I can definitely follow up to determine or to share specifically what is included in that count.
Thank you. It may be simple and I'm just not grasping it, but thank you.
Of course.
Okay. Any further questions on this slide? Okay. All right. So this page shows medical homes, and we show MODA at the top, the number of medical homes. So it's a little bit different from the providers. So these are actual contracted medical homes. Those who have a VBP contract. The second line is those who don't have a VBP contract, and then the percentage of those medical homes. Yes, can we? Thanks. With a VBP contract. So, for example, MODA in the top with no designation. There's 69 of those with no designation, but actually do have a VBP contract. But there are 202 with no designation and don't have a VBP contract. So the percentage of the no designation primary care homes with a VBP contract would be 25%. Providence is in the section in the middle, and then Kaiser's down below. So looking across the various tiers, I think you can generally glean that MODA has a higher percentage, has about 61% of their VPP contracts with medical homes. So 61% of their medical homes do have a VPP contract in this case. Providence in the middle, you can see the percentages are lower, and in total, that's about 28%. And then Kaiser down below, they noted that all of their medical homes, their physicians, have a VBP contract. So all 17 of those medical homes are considered to have a VBP contract in this case. One other bit of information. So the percentage of medical homes that receive care management fees isn't quite 100%, but it is 91% for both MODA and Providence in this case. Any questions? And we will go a little bit more to VBP, what the VBP contract is in the following sections. Okay. Some additional numbers here. So this is a breakout of payments to primary care homes and primary care physicians. So we have, again, MODA, Providence, and Kaiser in that order. We have the total paid amounts in the first column. So about 57 million for MODA for OAB and PED paid to primary care homes. Providence is almost 59 million, and Kaiser's 28 million. The amounts that were actually paid with no VBP contract for MODA was about 13%, or $7 million, a little bit over $7 million. For Providence, the number was higher, 28%, and that's about almost $16.4 million. Kaiser, all of theirs is under a VBP contract, and that VBP contract in this case would be Capitation, which would be, I guess the 4C, as shown, in the prior presentation. So focusing on MODA and Providence, the VPP contracts, those with VPP contracts paid fee for service, but not actually at risk. So, just services performed and you get paid no matter what, but you signed a contract with VPP elements to it. About 68% of the total payments for MODA were under, not at risk, but were under a VPP contract. For Providence, similar number, maybe just a little bit lower, 61%, about $36 million in this case. So the majority of the payments to primary care homes were done under a VPP contract, but there were no fees essentially at risk in this case, or it wasn't capitation or care management. So moving over, column to the right, one. So the amounts that VPP fee for service that was actually at risk and earned. So earned amounts paid to the providers. For MODA, the amount was about $4.5 million, which represents about 8% of their total payments. For Providence, the number was $675,000, which represents just over 1% of their payments. So MODA's payments were, about 8 times bigger. Well, actually, we're 8% versus Providence's 1%. So these were actually earned fees. And then I guess to be just skipping capitation care management for now and just moving to the far right, the VPP that was not earned. So there was about $6.9 million that was not earned under MODA. Providence did pay out all of their VPP, which were withhold. So what Providence told us was, because this is 2020 and due to the COVID pandemic, they actually made the decision to pay out all of the withholds, in this case, to the providers. So that was a decision done under the pandemic. So in this case, all of it was paid out. But for MODA, not all of it was paid out. The graph below kind of shows about 40% of the total that could have been earned was paid out. So there was a total of about $11 and close to $11.5 million that could have been earned. 4.5 was actually paid out, and about $7 million was not earned in this case. And then the two columns that I kind of skipped over, capitation, care management fees. So I referred to the 91% that were receiving care management. So you can see the amounts that were being paid there. On the capitation amounts, potentially some primary care providers, got paid maybe a little bit less than a fee for service and got paid capitated amounts instead. But the amounts are shown there, about $1.3 million for MODA, a little bit higher for Providence at about $3.2 million. And then Kaiser lists all of their fees under capitation at $28 million. Any questions? A lot of numbers. Okay. All right. If there's no more questions, then we're going to move on over to the qualitative findings. So this is kind of more of a general view of some of the written responses in this case. So what we found is use of performance guarantees in medical homes. It is a little bit mixed across the carriers. Specifically for behavioral health providers, there's very limited use of behavioral health provider performance guarantees. MODA has performance guarantees at 61% in the medical homes, which was shown on this slides before. They also have a behavioral health alternative payment methodology program that they're trying to put in with upside risk and performance guarantees. Providence, their performance guarantees are in 28% of their medical homes. Kaiser, I guess their value-based payments are actually kind of through the physician salaries, where the compensations based, can vary based on their quality, service, and meeting specific metrics, including behavioral health metrics in this case. All of the carriers do provide support to the medical homes, trying to achieve their performance guarantees. Some of the elements there, regular reporting, although the reporting does vary by the different plans. They do have in-person meetings to provide observations, opportunities, so they have the conversations to make sure try to help the plans, help the providers achieve their guarantees. And then Kaiser described talked about how their medical records are universal across their providers and how that helps with the performance and quality measuring and keeping on top of their patients' needs. Okay. The next slide, please. So in terms of care support for care coordination and focusing a little bit on behavioral health coordination. So care management fees for MODA to have referral networks within the medical neighborhood and community-based services. Providers with the embedded health practitioners. So, if they have health practitioners with that medical home, they are eligible for an enhanced care management fee in this case. For Providence, they have a team that's supported by Healthcare Service Hub. This hub provides support for crisis calls and helps navigate providers to find appropriate services, appropriate providers. So it helps direct them. And then Kaiser, they're integrated with medical health practitioners in the medical facilities, as clinicians as part of the care team. So they are there physically, and that's also are part of the care teams in this case. The quality metrics. So what we asked was whether quality metrics varied by the different tiers that the primary care homes were in. They did not for all the plans, but the metrics themselves in terms of what they are as well as the targets do vary. So they did vary by plan. While a lot of them were very similar, some of them were different between Kaiser, MODA, and Providence. And where they actually differ a little bit more as well were the targets. So Kaiser does target at the 90th percentile. MODA targets at the 75th percentile, and then Providence is kind of like a graduated targets where you get full funding on your, your withholds if you meet the 90th percentile. But it does range, I think, 50%, 75, and then 90% to meet the various elements. And then trend guarantees down below. So they are not included with Providence or Kaiser, but MODA does have a 3.4% target for a total cost of care for those providers and members attributed to those providers. Okay. That's actually, I think, the information that we wanted to go through. So are there any questions?
Emery, it's James. Not so much a question, and I think we'll hear more from the carriers on this, but the reason Providence and MODA look different is because their models are quite different. Providence is more of a downside risk, and MODA is more upside, conditioned on having some savings. So if a group has a good size savings, there can be quite a bit of upside potential. If there's not savings, there's not potential. So as you see the two and they look different, that's one of the big reasons why.
Okay. All right. If there are no other further questions or comments, we can just move on to the next slide, which will briefly describe the VBP contract. So compact. So this is VBP compact, which was signed by all the OEP and PEP carriers in late 2020. Kind of outlines the percentages and goals of trying to meet VBP. So the land category, we did show 3 and 4 there on the right. So second time you're seeing this, but land categories are there on the right if you need more detail. But for all payments, the threshold goals for 3A or higher are listed there. So this was what was in the compact. So, may differ from what was listed in the contracts for CCOs, but 35% by 2021 for all payments, 50% in 22, and then 60, and then 70% in 24. There's a separate element to the compact for primary care and general acute care hospitals. So that goal is a little bit higher. It's 3B and higher. So but the percentages also vary a little bit. So 25% by 22. So 25% for this year, 50% next year, and then 70% by 2024. So by 2024, the goal is to get all payments 70% in value-based payments. 3A or higher, but a little bit tighter 3B, which is shared savings and downside risk, or higher, or capitated or comprehensive payments by 2024. Okay, and with that, I guess I'll turn it back over to Margaret.
Yeah, thank you, Emery. Are there any questions or any clarifications anyone is seeking or would like to discuss related to any of this information before we jump into our next agenda item where we will hear from our carriers? All right, hearing no questions, we'll charge forward. And we are running on time on our agenda today, which is nice when it happens. So right on schedule. So first up, we're going to hear from two of our contracted carriers today, both MODA and Providence, specifically focusing on value-based payment implementation and progress toward the compact targets, specifically for those two carriers. We did, to talk with Kaiser and determined that kind of given where they are on value-based payments and their sort of different approach to care delivery, that for today's meeting, they would refrain from sharing any updates or comments, and we'll certainly have an opportunity to hear from them down the road as we continue with value-based payments as a critical topic for this work group. But that all said, today, I want to welcome Craig Anderson from Kaiser. And Craig, I think if I understand correctly, you might be standing in for someone presenting this today. So just wanted to say in advance, we appreciate you being available and thank you for being willing to come talk about this. And I'm sure you'll have lots to share, even if you weren't the original person intended to present.
No, that's great, Margaret. And I think you said Kaiser, just to clarify. I'm Craig Anderson from MODA.
Oh,
Health. And
yes, of course. Sorry about that, Craig. Thank you.
No, this has been great, and I appreciate the opportunity to come talk to you today. A lot of what's been covered so far I have on my slides, so it'll make things go a little quicker. So I should be able to stay on time, but please stop me at any point, and I'd be happy to answer any questions that you have. So go ahead to the next slide, please. So we heard about this earlier today from the APAC folks, and our data that we're showing is what was shown previously. And just to highlight, because of the nature of the annual filing of this data, it's done later in the year after the data is measured. So the data that we have available to look at today is from 2020, because that was put into APAC at the end of 2021. And I'll talk to any changes that we're seeing for 2021 and 2022 as we go through this. You can go to the next slide. I think we've seen this slide a few times today, so I'm going to go over that, and just you can go to the next one. This is meant to just provide some context. Here's the data that I wanted to start with, and this is, again, consistent with what was presented earlier today. However, it does provide a breakout between OEB and PEB, where I think previously this was lumped together. And really what's driving how this data is presented is our coordinated care model, which I'll refer to as I go through the slides today. It's really a primary care centric model that's driving these percentages. And just to orient you to the table that I have on the slide, what's on the left-hand side under the HCP land categories, number one is fee for service. And then 2C is the bonuses that we provide for quality, meaning quality metrics. And something just to mention, it probably it's been mentioned already, but a value-based payment has to have a quality component to be counted as a quality metric for hitting the targets that we're all trying to meet. So that's the piece of our coordinated care model that is attributed to quality. 3A is really where most of the dollars are, and that is our total cost of care model. And I'll go into a little more detail on that on a further slide. And then 4A, that falls under what's called an alternate payment model. And some of this is modeled under CPC Plus, if anyone's familiar with that program. And under CPC Plus, primary care providers were given an option to accept capitation for certain office visit codes, and we've retained that under our CCM model. In terms of how this has changed since 2020, I just want to highlight that the majority of dollars that are falling under fee-for-service, you can see it's quite different for OEB and PEB. And OEB is slightly different. So unlike PEB, OEB does not have a statewide plan, a separate statewide plan. So the way we've set up our plans for OEB, people have an option. It's incentivized through the benefits, but people do have an option to join the coordinated care model and select a primary care provider or be attributed to primary care provider. So we just have more people on OEB that are choosing not to do that. Under PAB, because Providence offers a separate statewide plan, everybody is in the coordinated care model, but some of those people don't have PCPs. But those numbers should decrease, the fee-for-service numbers, as we get more people into the coordinated care plans for both OEB and PAB. We're doing a better job through this incentive on the benefit side to get people to join the CCM model, and we're seeing that in 2021. And for PEB, we're doing a better job of attributing members. And I'll talk about attribution a little bit later in this presentation. You heard a little bit about it earlier today as well. So you can go to the next slide, please. So really what we're trying to get to, and you saw some of the targets that Emery presented, but there's 3A and 3B. But the main thing to point out about 3B, it's this element of adding downside risk. And we've been very successful in getting primary care providers, particularly PCPCHs, to join our coordinated care model and take the upside risk part of that, and to manage to a total cost of care, which is really important. But moving providers, mainly primary care providers and hospitals, is where we're trying to get the downside risk traction. It's been somewhat difficult, really. And I'm not trying to make excuses, but I think you heard it earlier today. COVID has caused a bit of a disruption in the provider community. So there have been distractions there. And also when you're dealing with providers, you're trying to get them to accept downside risk, you need some certainty or some, I guess, consistency in how claims are being paid or what to expect. And COVID's made that a little bit more difficult. So it's caused us a bit of a delay, but we're definitely pursuing that, and we've been pursuing that on other lines of business as well. The other thing that's been a little bit challenging on the hospital side is Senate Bill 1067, which put a cap on at least DRG hospitals on their payments. And that cap does apply also to incentive payments. So that's been a bit of a challenge there. And also with the reset of how they're getting paid under OEB and PAB, it's taken away a little bit of their enthusiasm about taking downside risk, but I think that, again, will be changing, and we continue to pursue that as the hospitals get accustomed to the new payment rate. And really where we see the most traction that we expect to get into 3B and downside risk is on the primary care side. We're getting traction there in some of our other lines of business, namely the CCO. So it's really just an evolution process. We get the providers to accept a certain payment model, get familiar with that, see that there's ways that they can influence the outcome, and then introduce the downside risk. So that's where we're really focused for 2023, is on the primary care side, at least initially. But there are ways to get value-based payments in all provider types, and I'll finish up with a comment about that at the end of this presentation. Can you go to the next slide, please? Just really quick, our coordinated care model, as I mentioned, is our primary vehicle for value-based payment for OEB and PAB. It's a primary care centric model, has these 4 different elements, and I won't go into great detail about all of these, but because I mentioned them earlier. But I think the things to highlight here is the primary care capitation is something that's offered to primary care providers. And one thing about COVID that made this a little more attractive to providers is when you're reliant on fee-for-service and there's a shutdown, you run out of your fee-for-service payment. So we did get more traction and more interest in capitation because it does provide that prepayment for services, and we're building on that as well. It's really that total cost of care component 3A, if I could draw your attention to that. It does apply to all providers, all primary care providers. It's not optional. And the main point of this is that third bullet, which is that we're making the primary care providers responsible for all costs, not just the cost within their primary care clinic, but all costs to the members that they manage. And you heard Sarah talk earlier about how the total or the cost containment or the sustainable cost containment growth target program is set up. It's also set up based on primary care providers managing a population, and that's aggregated across all payers across the state. So our total cost of care model that we have for OB and PEB aligns perfectly with what the state's trying to do. So I think that's a really nice element of how we've set this up. And of course, we have the quality incentive, which is required. And then lastly, care management fees, which was an aspect of CPC Plus, but it's really that prepayment to ensure that the primary care providers have are reimbursed for all of the infrastructure that they have to build to support what they're doing. So you can go to the next slide, please. This is sort of a conceptual slide, and again, kind of reinforcing why we are so supportive of our coordinated care model. And you can see on the left-hand side of that diagram, it's the primary care provider that we see as really the ones responsible for the population, and they're the ones that are influencing the total cost of care by how they're referring their members, whether they're referring them to specialists who then refer those members to additional specialists. They have to know how that referral system is, how efficient it is. And we do that by providing them reporting on how they're managing to the total cost of care, and also conversations with them about referral patterns and how they compare to other providers. So it's a real intensive approach that we take with data sharing with providers, but it's because we see them as central to controlling really the specialty and hospital and pharmacy services that their members access. You can go to the next slide. So this slide is, again, sort of a conceptual one, but we think it's important, again, to help describe why we're taking this PCP centric approach. And really, it's a comparison of two ways to look at controlling cost of care or incentivizing the reduction of services, essentially, to more efficiently manage care. So when you think about this from the point of view of a provider, where we're incentivizing that provider by him or herself to reduce the services that they're providing, there's a bit of a dilemma there. And so if you follow me through this top table, if you're asking a provider who's relying on fee-for-service for all their revenue, we're trying to incentivize them to reduce or to accomplish savings through initiatives. So right off the bat, if they're successful in that, they're reducing their fee-for-service reimbursement. So it's a difficult balance there to get that incentive to work. The way we get that incentive to work is we say that, well, for whatever savings you get from your own services, you get to retain part of that through a bonus, but a part of that does go back to the plan. And in the case of OAB and PEB, it goes back to OAB and PEB. So they get to retain a portion of that. So when you get to the last two columns of that top chart, what you see is that if a provider is successful under a model like this, where we're really trying to incentivize them to reduce their own services, their fee-for-service revenue decreases, and then they get just a portion of the savings from the services that weren't provided. So on a per unit basis, they do receive more revenue, but overall the revenue is decreased. So it's we're really having to get a provider to buy into a program like this by telling them, well, you know, your marginal income will increase, even though your overall income is probably going to decrease. On the bottom chart, the reason we like the approach we're using with the primary care providers is the primary care providers their direct fee-for-service income is only a portion of the total cost that they control. And that's shown in the bottom chart on the far left side. So if you think about that in terms of the population that the primary care providers are responsible for, they do fee-for-service on just a portion of that, and the rest of that that bar is made up of hospital services and emergency room services and pharmacy services, and that's what they control. So when you incentivize a primary care provider to reduce hospital and specialists and other services, that's not really coming out of their own fee-for-service revenue. So the model works similarly. They get a portion of that savings. And what that does, when you get to the right-hand side, their fee-for-service revenue doesn't decrease year over year, but they actually get additional revenue from the savings that they achieve. So that means being successful under this model does increase revenue at the end, and that's why we support this approach. Can you go to the next slide, and please? Just really quickly on this, I do want to leave some time for questions. I mentioned quality metrics. Quality metrics is something that the Oregon Health Authority manages through their Health Plan Quality Metric Committee. What we're trying to do is just align metrics across all programs. It keeps sanity with our providers if they're not jumping around to different metrics by different programs, and that's something that we're trying to do and achieve. And it also lines up with our performance guarantees with OAB and PEB. You can go to the next slide, please. Kind of to summarize here real quick, in terms of what we see as the pillars of success for value-based payment is really three different components here. The financial incentive, of course. We think that it's really important for it to be simple, and the reason for that is providers have to understand what they're doing, how it translates directly to their financial incentive. We can develop elaborate schemas and models, but if the providers don't understand how it works, it's not effective. And we also have to make sure that the incentives are achievable, so they don't feel like it's too high a bar every year to do that. And lastly, that it's aligned, and we know through the value-based payment compact that there's a statewide effort to align these as well. Data sharing probably goes without mentioning. It's really critical. And when I started in this business 30 years ago under an HMO, we didn't have this data sharing. So it's really makes all the difference in the world to provide actionable data to the providers and make sure that the data we're providing really meets the provider where they are. A lot of providers are very sophisticated, and we just do data downloads into their own systems, and other ones need reports that really spell things out. So we tailor our reporting in that manner. And then lastly, none of this would work without clinical engagement. And we have to make sure that the providers' clinical teams also understand how the incentives line up to the work that they're doing. And really maybe the most important thing is that we're collaborating. This is not just an OAB, or it's not an OHA force thing, it's not an OAB force thing, it's not a MOTA force thing. It's something that we collaborate with the providers. And you heard that from Sarah earlier today. It's really meant to be something we're all in this together. And we've had great conversations with providers on these models, and great input too. Last slide, please. Oh, okay, second to last slide. This one is just talking about attribution, and I could spend a lot of time on this. I think I'm just going to say just one quick thing. Just sometimes our main goal is to have people select a primary care provider, but we know that people don't always do that. So what we're trying to do is make sure that we are aligning the right member with the right provider, because we're holding that provider accountable for that member. And if we don't get that right, then some of this doesn't work very well. So we've been working very hard to make that all work. And that's what we've been doing in that area. You can go to the next slide, please. All right, this is my last slide. And just to give you a sense, we are always evolving these models, and we are doing these in our other lines of business, our individual line of business, our CCOs that we support. So there are different models here. I think that I'll just highlight maybe the second one here, episode-based. It's something that we've been talking about with the Centers of Excellence. It's really a way, I think, that we see getting specialists engaged. We know that's very important. So we're looking at doing that in terms of having episodes that we set targets and aggregate specialty types against each other. The challenge with that is really just the number of providers that we're able to, or the number of episodes that we're able to do for statistical reasons. But again, if we can get that alignment across all payers, I think we have a lot of opportunity there. And then there's just some other opportunities that we're looking into on the hospital side too. So in spite of my mentioned earlier about some of the challenges we're having with engaging hospitals, we are getting traction, and we're looking at different models there as well. So I'm up against my time, but I'll be happy to answer some questions here.
Great, thank you so much, Craig. Are there any questions?
Thanks, Craig. You ended right on time.
Did my best, Jeff.
Thank you.
Yeah, you're welcome. Thank you.
All right. Yes, thank you. And hearing no questions, although I'm sure, you know, as I said, I think as we look ahead to working toward achieving the value-based payment targets that have been established in the compact, we will certainly be continuing to engage with our carriers on this. So we may not have questions today, but I'm confident, you know, those will continue to evolve. That said, I think we will move on. So next up on our agenda, we have Providence Health Plan providing an update on value-based payment implementation relative to the compact targets. And I think Stephanie Dreyfus is going to be presenting today. Is that correct, Stephanie?
Yes. Yes. Can you hear me okay?
Yes, we sure can. Thanks for being here.
Okay.
Great.
I'm
Yep,
on.
I think, yes, I
Okay.
think you can take it away once you're ready, for sure. Thank you.
Oh, okay. So thank you. I'm Stephanie Dreyfus. I presented to all of you last month, so I'm delighted to be back to talk about value-based payments. I'm going to start by really talking about our very deep, long, robust history on risk sharing on the Medicare and Medicaid side. So on the Medicare side, we have almost all of our membership flows through some kind of total cost of care risk arrangement. These are primarily have upside and downside. They are all of our Medicare members are assigned members. So these are with hospital-based integrated systems, they're with IPAs, we have them with individual medical groups. There is very robust risk sharing. They are designed on a total cost of care basis, which means kind of the revenue is the total CMS revenue, and then a medical loss ratio is set. And that is really the financial target for the provider. There is lots of nuances between the arrangements, but that is the basic financial structure. We also couple those with a quality incentive program that's based around the STARS measures. And those are, those measures are relooked at every year depending on the emphasis of the STARS program, what the thresholds are. But that we have a quality incentive program coupled with the total cost of care target. The risk sharing is very primary care focused, although in some of our IPAs, the specialists do also participate in the risk arrangement. And some of our arrangements, the hospital also participates in the risk. And we just recently rolled out in Portland through a new high performing network, new risk sharing with the specialists, where they are really sharing community-wide risk on a total population. On the Medicaid side, because of changes that happened in health share a few years ago, all of Providence health plans or health assurance Medicaid members really are assigned to Providence or one other large community pediatric group that is partnered with Providence to serve this membership. And our delivery system takes full financial risk for these members. So we partner with them very closely in terms of data sharing and providing, working really closely on the model, but they are full financial risk with this community pediatric groups. And we also have a quality incentive program based on the OHA measures. And as you know, most of the OHA measures are primary care focused with one OBGYN metric, which we do. Our OBGYNs or anybody who does deliveries participates in those measures. So these models have been in place for a very long time. They are supported by robust data. We recently rolled out a new model for the first time to really try to address small practices that simply don't have the membership to really operate well in a total cost of care model, or in some cases, honestly, don't even have enough of our members to operate in a standard quality incentive model. So we rolled out a model that gave them the opportunity to earn an incentive even with low membership. Okay, next slide. On the commercial side, it's a little bit different story. So we have, and as you all know, commercial is far more complicated than Medicare and Medicaid. We have assigned members and attributed members, whereas on our government programs, they are all assigned. It also cuts across many lines of business. So individual is different than small group, than large group, than fully insured. And of course, like PEB and OEB, we have self-insured groups, and they are financed differently. So on the commercial side, and the members have very different benefits. So on the commercial side, total cost of care is more complicated. That being said, we have worked really closely with a couple large integrated delivery systems and some other hospitals and medical groups to create a total cost of care structure. And again, it is based on a kind of total revenue target in some cases, and in some lines of business, we have based those off of an MLR target, so total premium, and the target is set based on achieving a medical loss ratio. And this can be for a defined population of either assigned or attributed members, or it can be a population in the entire community, like a county. We also have models where rather than having an MLR target, it's really, we call it beating the trend, so that the target is really doing better than the community trend. And again, we have done this for a defined population or across the population assigned to an entire community. And then we have a very 15 or 20-year history of pay for performance. Most of our primary care providers with enough volume of our membership participate in our quality pay for performance program. It's generally funded through a withhold, so they take risk on their fee schedule towards quality metrics. The metrics are based primarily on HEDIS measures. And again, we looked at every year in terms of looking at the HEDIS measures and the thresholds, and our primary care physicians are able to choose from a menu of metrics that they want to work on that year. So they are able to kind of, in their own practices, if they're focused on certain things, for instance, with other payers, it gives them the opportunity to not have 42 different quality metrics across all the different payers, but try to align and really focus on strong improvements in those measures. Okay, next slide. So in terms of the percentage of dollars looking that flow through these value-based agreements, so I want to be really clear, these aren't the dollars at risk. These are the total spend in these lines of business that are essentially accounted for in a risk arrangement. So on Medicare, for instance, because the majority of our members actually are members are assigned to medical groups or IPAs or high-performing networks that participate in a risk arrangement, almost all of the claims in the state in our Medicare line of business end up kind of flowing through a value-based agreement. On Medicaid, it's 100%, which makes sense because our own Providence delivery system takes 100% risk on 100% of the Medicaid members. And then for commercial, it's 28%. And I just did want to point out that that does include two large self-insured employers who have risk arrangements directly with a large integrated delivery system. And then I just wanted to conclude on this slide that when we look at the total allowed dollars per the target, more than 20% of the spend is going to primary care. Okay, next slide. Okay. Just to go through a little bit the specific non-fee-for-service payments on the commercial side. So we do pay, we have our Choice Medical Home Network, and we're generally paying and have for a number of years a care management fee to those primary care. So that's in addition to their fee-for-service basis to, again, fund things like infrastructure or services that are not currently reimbursed on a fee-for-service basis. For the comprehensive primary care program we developed, we were the only payer in Oregon participating in Medicare commercial and Medicaid to participate in the full 9 years of the CPC program. So the first 4 of CPCI and the second 5 of CPC Plus. We decided this year, as that program sunsetted, to create and offer a bridge program for our providers who had participated for basically 9 years through the CPC program, to give them a bridge program with some continued funding. I mentioned our pay for performance program. We have commercial risk sharing and then individual shared savings and risk sharing. And then on the behavioral health side, we have a program called the BH Concierge program, where they are paid through a case rate. So rather than a fee-for-service rate, they are paid through a case rate. We have primary care capitation on the commercial side, of course, where we have assigned membership. And then for PEB, if we have a medical home that is not being otherwise paid through one of these other, we don't pay a care management, we only pay one care management fee per member. But if they're not otherwise being paid through a medical home care management payment or some other mechanism, we are making a payment if they are PCP certified, or sorry, PCPCH certified. Okay, next slide. I just wanted to talk about 2 other alternative payment arrangements with our two point of care arrangements. We have VRTA, which is a type 2 diabetes reversal program, and that program is based on a flat fee per member, based on actively engaged members in the programs. And then we have our digital Kaya, the digital PT program, and that is also a fee, that structure that is tied to the active engagement of the member. Okay, next slide. I did want to just take a minute, although certainly the goal that we strongly support and align with is to move away from fee-for-service. We do recognize, at least in our current environment, that sometimes there are fee-for-service payments that very directly and very much support members getting the care they need in a cost-effective way and really getting access that sometimes can be challenging. So we are currently paying for e-consults between primary care providers and specialists, and this allows a primary care, if they have a patient in the office that they believe might need to be referred to a specialist, to actually have the opportunity, in the quote unquote olden days, I think this used to operate as a curbside consult, and that simply just, we don't live in an environment anymore where that really exists. So this allows the primary care provider to consult with a specialist and potentially not need to refer the member. And this really helps on patient access and, of course, on cost. And then we do also pay the BH collaboration fee, which allows a primary care practice to better support a membership that needs behavioral health services. But we know access, given our last presentation last month, access can be a real challenge, especially with psychiatry. So this allows for the opportunity to potentially get more robust support in the primary care setting. Next slide, please. So on the for the Medicare and the Medicaid side, as I reviewed, we have risk sharing. We have a very robust quality. And I'd mentioned both on the commercial and the Medicare and Medicaid side that we have a really great primary care PCP profile. So they have great access online to all the quality metrics, where they are in meeting those quality metrics, which members where there are gaps, to identify the specific members to close those gaps, and really good support and clinical and strategic account management support. And again, this is both on Medicare and Medicaid and commercial. We started this year with an IPA outside of Portland, pharmacist collaborative, where we're paying a PPM, both to support the pharmacists and the data sharing with the providers. And this particular IPA has a Medicare risk contract with a withhold, and they have dedicated part of the withhold return to meeting some specific metrics through this program. And then on the Medicare side, and we also pay a management fee. And then I did not include it on the slide, but we do also pay primary care capitation on Medicare and Medicaid. Okay, next slide. On PCP assignment, PCP assignment is very much linked to, I think, the ability to, or a better, stronger ability to roll out robust value-based arrangements. The PCP or the medical group knows who their assigned members are. The members know who they have chosen. They, through benefit design, have a different relationship with the primary care physician. So like on Medicare and Medicaid, that really is one of the things that has supported the value-based evolution. And on the commercial side, is a more conducive path to the value-based agreement. That being said, we are working hard and do have total cost of care and quality based on attributed membership. But you know, I think if we could, we would certainly have more PCP assignment, you know, within the state. So for Medicaid, 100% of our members are assigned, choose or are assigned to a PCP. On Medicare, it is the same. On the commercial side, we have two networks choice, which is a network that PEB members have an option to choose, and then Connect. And both of those products have also, members actually choose a medical group or a clinic versus a PCP, but they are required to choose primary care or a medical home. And then on our non-PCP assigned products, we do communicate to members the importance of choosing a PCP, the value of choosing a PCP, but we do not require it, and we do not, through attribution, we track it. And again, through the quality programs or any programs where the provider is at risk, they know who their attributed membership is. But we do not track it, for instance, in our claim system or our membership system. And on PEB, to further kind of promote the concept of choosing a primary care physician, if a member does go to a primary care practice that is PCPCH certified, they have a little bit better benefit than if they don't. Next slide. Okay, I'm sorry, this is really small on the barriers and challenges. And I would say these are all barriers, challenges, and opportunities. So one of the first things we really have focused on when we have created value-based agreements is to make sure that there really is return and it really is benefiting the marketplace. So we really have tried to make sure any program that for us PEB is involved in, that this is not a short-term cost increase to PEB, that really we are trying to find opportunities that do create savings and of course increase in quality. I think as you heard from the MOTA presentation, providers in some cases, if they're smaller primary care practices, really cannot take a lot of downside risk. And if they're at risk for total cost of care, I mean, their entire payment really doesn't allow for them to shoulder much downside risk, which is why we have partnered a lot with larger integrated delivery systems to really start to roll out total cost of care where there is more risk. But we are moving, you know, we are like MOTA, really focused on trying to find solutions, both for our primary care providers and our larger practices. You know, one solution to this is to encourage primary care practices, either consolidation across payers, but, you know, even the way they have consolidated into IPAs or larger organizations to support risk-taking on Medicare is something that we hope to be able to enable or support in the future. The last 2 years, as you've heard about and know, has been a little unpredictable given COVID, to try to set a baseline and have some predictability. We also are very cognizant that that part of the purpose of doing risk sharing is to reward providers, absolutely, and to reward for their improvements in total cost of care and quality. But we also want to make sure that we continue to be able to return savings to the market while keeping a sustainable shared savings that is attainable, and that continues to reward their performance, but again, while continuing to return some savings to the marketplace. Membership, as I kind of alluded to, often for small practices is just too small to participate in a total cost of care arrangement on their own, or even sometimes, even though the thresholds are smaller, in our quality program. ASO groups, we have to have their consensus one by one to participate in the risk programs, which I think they have often been kind of carved out, which is not really, doesn't work very well for, again, a primary care practice or any practice trying to manage across their population. And again, and you've heard this, that it's really hard for them to effectively manage in different kinds of programs. I would say another challenge is just really trying to find the effective program. CPCI and CPC Plus, we all worked on it for 9 years. Everything was aligned. It was just a great opportunity for payers and Medicare to work together.
Yeah. Oh, Stephanie, I think your sound went off. We can't hear you. I think your mic was muted.
Oh, sorry. Am I back?
You're back now. Yeah, we lost about the last 30 seconds. So.
Okay. Oh,
but we can hear
was the
you
most
now.
important. Okay. So I was just going to say that, that one of the challenges is finding programs that really work. And with CPCI and CPC Plus over 9 years, it was a great program and aligned across many payers. It gave, including Medicare fee for service. Providers had lots of support. And in the end, at least for Providence Health Plan, we did not get any total cost of care savings compared to a cohort or any improvements in quality. And I think this was borne out in lots of places in the U.S. So it's just a challenge to find the right program. On our bundled payments, we had a really robust total bundled payment for several years on the inpatient setting, and really good participation from the orthopedic providers in the hospital, found savings in the post-acute. And then what happened was total joints started to transition to the outpatient and to the ASCs. So the volume on the inpatient decreased, and the savings that could be achieved just through transitioning to the ASC setting or the outpatient setting so far exceeded the savings that could be generated in the bundle that we eventually, with the agreement from the providers, we ended up sunsetting the bundle simply because the care had shifted so dramatically at least on the commercial side, into the ASC setting, where really the savings are immediate and were much more substantial. I'll try to go fast to get through these routes. We have to always be sure we're not sharing risk twice, and that's a challenge when, we share risk with primary cares, but we want to do other, sharing with specialists who are caring for those same members. So trying to integrate multiple risk sharing across the same population certainly makes it challenging. And providers want risk that they can control and manage. And we understand that, but we have to find a balance between that and, they have to be able to take risks for things they can control, but you can't narrow it down so much that it's not credible or so big that they don't feel like they feel like they're taking underwriting risk. Okay, last slide. So as we look to the future, certainly we continue to look for ways that we can create incentives that primary care providers and large integrated delivery systems can feel comfortable taking downside risk, that it's risk they can manage, and that we can provide the data to support them and the infrastructure. But it's got to be a structure, obviously, that is sustainable for them and a structure that is able to return savings to the marketplace. Our most recent innovation is we are in active discussions with a new high-performing network formed in Portland about a potential proposal for PEB to come back to PEB to talk about a potential risk sharing on the PEB membership. And this is primary care and specialty. So it's a great opportunity to work with the specialist and the primary care on perhaps developing something that would work for the PEB population in the Portland metro area. So sorry, I went a little bit over, but if there are any questions.
Thank you, Stephanie, for all that information. And I think I see a hand up, so I think we do have some questions. Ali, it looks like you raised your hand.
Yeah, thanks, Stephanie. Good presentation. I know Senate Bill 1067's made this all really challenging, challenging process to begin with. But how do you see Providence tracking against the VBP targets that are very specific? And 2024 is just around the corner.
So
yeah.
Yeah, so I'm sorry, I don't have those. There's kind of an echo. I'm sorry, I don't have those numbers. And so I'm going to need to follow up specifically on, I'm sorry, I don't have the numbers. I need to pull out the numbers from a different presentation. So if it's okay, I will follow up with you specifically on how, because we just completed that report.
Yeah, we can talk further, no problem.
Okay.
Are there other questions? Did I see another hand, or oh, maybe it's down now. Well, Stephanie, I will just say that last bullet point you mentioned on the last slide definitely piqued my curiosity. So I'm certainly interested in anything further that you can share there, and that might need to be, that might require another meeting or some other sort of touch base, but certainly interested in hearing more about that.
Okay, I'm happy to.
Great.
Thank you.
Thank you very much.
Any last questions? Any public comment? Anything more, Margaret, before we adjourn?
No, I don't have anything further for today. As long as and Rose, you confirmed we are we don't have anyone who has submitted public comment, correct? I neglected to check with you before the meeting.
No public comment.
Okay, thanks for confirming that.
Well, thank you then. And with that, our meeting is adjourned. And next month,